coming to de Quervain's disease, it is a very commonly seen in our day-to-day clinical practice. It was first described by Swiss surgeon Fritz de Quervain in 1895 as tenosing tenosynovitis of the first extensor compartment. The commonly seen age group is 30 to 50 with male to female 1:6 ratio, commonly seen in dominant hand. There is classical pain over the radial styloid proximal to the wrist joint. It is related to acute or repetitive trauma that restrains gliding of the tendons, resulting in inflammation of the synovial sheath, leading to reactive fibrosis and thickening, and hindrance to movement of EPB and APL tendons in the first compartment. So it is the predisposing factors are overuse, injury, repetitive tasks that involve overexertion of the thumb, radial and ulnar deviation of the wrist repetitively, arthritis, and some conditions like pregnancy can give rise to this tenosynovitis. Many of the times there are seen anomalous slips of the APL and EPB, maybe 2 or 3 in number in majority of the cases. So there is a radial styloid pain associated with visible swelling, tendon sheath thickening, hardness, tenderness. Pain is aggravated by movement of the thumb. There are so many tests advocated like Eckhoff's maneuver, when the patient makes a fist with the thumb inside and force ulnar deviation reproduces the pain over radial styloid. Similarly, the Finkelstein's test, which was originally described as active ulnar deviation of the wrist with the surgeon passively flexing the thumb into palm, which produces pain. And other maneuvers like wrist hyperflexion and abduction of the thumb, as well as abduction of the thumb with wrist in radial deviation. These maneuvers produce pain over the radial styloid. So the differential diagnosis includes CMC arthritis of the thumb, which can be ruled out by crack and grind test, and there is classical tenderness over the CMC joint all around the base of the thumb. Scaphoid fracture can be ruled out by tenderness in anatomical snuff box. Schaffer's fracture can be ruled out by seeing X-ray. In intersection syndrome, this may mimic radial styloid pain, but it is more or less proximal pain related to tenosynovitis of the second compartment. So initial treatment is conservative treatment with splint, cold packs, laser therapy, and NSAIDs for 6 to 8 weeks to reduce pain and inflammation. And one may try corticosteroid injection inside the tendon sheath if the pain is moderate to marked with conservative treatment more than 3 weeks duration. For failed conservative treatment, one can go for surgical release. It is important to note that the superficial radial nerve has its branches in close proximity of the first compartment. So when we release, we have to take care of these nerve branches. So this is a short video. This is done under local anesthesia under tourniquet control. I prefer transverse incision over radial styloid. And the soft tissues, including the nerve and the vein, are well retracted by right angle retractors. And the sheath over APL and EPB is released with a scissor. Usually the sheath is 2 centimeters long over the radial styloid. So this is how the video is not running. Anyway, after release of the compartment, the gliding of the tendon is checked with movement of the thumb. Passive and active movement is advised. It is checked, and once the release is complete, then the incision is closed and the patient is advocated active mobilization the very next day. There are complications associated like infection, or tenderness over the incision site, sometimes damage to superficial radial nerve. And if this occurs, it may lead to painful neuroma and CRPS. All these complications are preventable. If you get a painful neuroma, it is better to excise the neuroma by extensile incision and excise the neuroma and do end-to-end nerve repair, neurolysis, or wrap the nerve ends with a vein graft or a fascia and then close, and that will give good pain relief. All these complications are preventable. Thank you.